Dr. Navneet Chabra.
Good afternoon, everyone. I'm Dr. Navneet Chabra from Shankar Netralaya, and today I'll be presenting on Beyond the Obvious, Subtle Clinical Signs and MRI in Diagnosing Pituitary Adenoma. Pituitary adenoma are common intracranial cellular tumors which presents with the symptoms of either hormonal changes or visual dysfunction. In our case series, we present 7 patients who had subtle clinical ophthalmic and systemic signs but with suspicious disc. On evaluation of MRI, we found them to be having incidentalomas or pituitary adenomas. It was a retrospective observational study conducted by reviewing the medical records of patients who presented with suspicious disc or referred to the neuro-ophthalmology clinic of a tertiary care eye center. Detailed history, clinical examination along with their visual field, OCT RNFL and MRI findings were noted. Our first case is a 47-year-old male who presented with diminution of vision in left eye since last 3 months. The patient also had a past history of road traffic accident 10 years back, and on examination we found him to be having a 6/18 visual acuity with mild temporal pallor. But his visual fields were surprisingly showing advanced field defect in the left eye and temporal hemianopia in the right eye. Our second patient, a 34-year-old male with history of trauma to left eye with a rubber ball, showed a visual acuity of 6/18 in the left eye with temporal pallor. But his visual fields were normal. As there was a clinical and diagnostic mismatch between the visual fields and the history of the patient, we went ahead and ordered an MRI. And the MRI showed us pituitary macroadenoma. So in all patients of ocular trauma, they may not be a traumatic optic neuropathy. If the disc and visual field findings are not correlating, an MRI can help us in clinching the diagnosis. Our third case was a 47-year-old female who presented with diminution of vision in left eye since last 2 years, associated with headache, nausea and vomiting, but no tinnitus. She had a hand movement visual acuity with temporal pallor. Her OCT RNFL in the left eye showed temporal thinning, but the visual field showed right eye temporal hemifield defect. To find out the cause of raised ICT, an MRI was ordered which revealed pituitary macroadenoma. So in patients with raised ICT and reduced vision field defect, MRI is advisable. Our fourth case was a 19-year-old male, a known case of juvenile open-angle glaucoma on glaucoma medication since last 1 year. But he had reduced vision in one eye severely to counting finger close to face, while the other eye had a visual acuity of 6/18. His optic disc were showing both eye severe disc pallor, and the left eye visual field showed a temporal field defect respecting the vertical midline. As these findings were not suggestive of glaucoma, an MRI was advised, which again showed us pituitary macroadenoma. So in glaucoma patients with pale disc hemifield defects, MRI is recommended. Our fifth patient, a 67-year-old female with primary open-angle glaucoma on glaucoma medication since last 3 years with a cup disc ratio of 0.5, presented with sudden onset diplopia since last 4 days associated with an esotropia and abduction limitation. Her OCT RNFL and visual fields were normal, but she had sudden onset diplopia. To find out its cause, an MRI was done, revealing pituitary macroadenoma. So in glaucoma patients with sudden onset diplopia strabismus, MRI is recommended. Our sixth patient, a 48-year-old male with diminution of vision in right eye more than the left, he also had a past history of completing an antitubercular treatment and presented with a visual acuity of 3 meter in the right eye and bilateral temporal pallor. His OCT RNFL though was normal, but the visual field showed temporal field defect in the right eye. Since the findings were not suggestive of ethambutol toxicity, we ordered an MRI showing pituitary macroadenoma. So in ethambutol toxicity patients with asymmetric vision and field defect, MRI is warranted. Our last case was a 68-year-old male with diminution of vision in right eye since 8 months associated with a history of chronic tobacco addiction. He had a chalky white disc with 3 meter vision in the right eye with a severe thinning in the right eye OCT RNFL, but the visual field and OCT in the left eye were normal. As the findings were not matching with toxic optic neuropathy, an MRI was advised suggesting pituitary macroadenoma. So in toxic optic neuropathy patients with reduced vision, RNFL thinning and no central field defect, neuroimaging is an advisable investigation. Pituitary adenoma patients can present with optic nerve dysfunction due to a compressive optic neuropathy. They can also present with systemic symptoms due to altered hormonal levels or raised ICT. Visual fields and OCT, along with history and investigations, help us in early detection of these lesions. OCT changes may precede the field defect, and RNFL loss does correlate with the postoperative visual recovery of patients. Our patients had history of trauma, glaucoma, antitubercular treatment, and addiction, but their marked temporal disc pallor and field defects along with neurological localizing sign prompted us for neuroimaging. So, MRI in patients with suspicious discs and clinical diagnostic mismatch can help us in incidental diagnosis of pituitary adenoma. These are my references. Thank you.
Very good.
Did you get anything other than the pituitary adenoma on MRI?
Yes, ma'am. 2 patients did have meningioma. Since the series was on adenoma, we did not include them, but we did find meningioma also in 2 patients.
So basically, imaging is important in all, optic nerve diseases.
Lesions. Yes, ma'am.
How many had enlargement of the blind spot?
So enlargement of the blind spot was seen in all of them because they had a temporal field defect. In whichever patients we could do a field testing, those who had reduced visual acuity of hand movements, visual testing could not be done.
How many had superior temporal compression?
So 1 patient had a superior temporal compression.
Can you tell us why diplopia happens in a case of pituitary adenoma?
Ma'am, diplopia can happen in the patients of pituitary adenoma because of the compressive nature of the tumor compressing the 6th cranial nerve.
Is there any other mechanism, and was there any abduction deficit in these patients?
Yes, ma'am. In 1 patient, we had abduction deficit who presented with sudden onset diplopia. There is a clinical entity in which the patient may have diplopia, but there is no reduction in the extraocular motility of the patient. So we can have that kind of clinical condition.
What is that called? Is there any name to it?
Yes, ma'am. It is a named condition, but I do not know the specific name.
Very good.
Thank you, ma'am.
Sometimes in some atypical case of chronic glaucoma with the unusual field defects, it's very important to do to exclude pituitary adenoma. Very good.
Thank you, sir. Thank you, ma'am.